Thanks, Dr. Hartley, and thanks to the GME office for your partnership this year and in making this keynote address successful. I would like to welcome Dr. Rob Gonsalves to our keynote address speaker for this year. We celebrate 10 years of Quality Day this year, and I think the talk that he's about to give is really tells the story of Quality Day at Phoenix Children's. 10 years ago, Dr. Brig Willis and Dr. Michael Olson, leaders in our graduate medical education office, really started this day as a way to really kind of lay the groundwork in quality improvement science and really have that be incorporated into all we do and how we improve patient care. I think the story Rob's about to tell just really highlights how our endocrinology division under his leadership has done that. Rob came to Arizona and attended the Arizona College of Osteopathic Medicine at Midwestern University. He completed his pediatric residency at Emory University and then returned to Phoenix Children's to complete his endocrinology fellowship, where he's been faculty since graduation. He is a leader in quality improvement, both within his division and for our hospital, completing several certifications. I'm really excited to hear his story and the division story today. Please help me in welcoming Dr. Gonsalves.
Okay, thank you everybody, and thanks Kelly for that introduction. Get this keyboard up here. Okay, here's our agenda. All right, so yeah, 10 years of Quality Day. It's a pretty impressive milestone, and I really am honored to be able to speak with you and share the work we've done in the endocrine division, specifically with regard to type 1 diabetes. So I wanted to take this opportunity to really reflect on what 10 years of quality work looks like within a clinic. So I'm not just going to give you the greatest hits of our quality work over the past 10 years, but really show how quality helped shape the way we think about our problems and our patients, how it's changed the way we communicate within and beyond our division, and ultimately, as my talk shows, how it changed our clinical culture. So the growing challenge, and first of all, I have nothing to disclose, no financial disclosures. So to understand the issue, we need to understand a little bit about type 1 diabetes. So type 1 diabetes affects 2 million people in the United States and about 8.5 million people worldwide. Nearly 4 in every 1,000 children and adolescents in the United States has type 1, making it one of the most common chronic diseases in childhood and in pediatrics. The incidence of type 1 diabetes is increasing, and we don't quite understand all the reasons why. But if you see here, about 1.5 per 1,000 was the incidence in 2001. Just a and up to 2.1 per 1,000 in 2017. And then again, in the last 10 years, it's almost doubled to the 4 in 1,000. So our patient population is rapidly growing. So type 1 diabetes is autoimmune destruction of the insulin-producing cells in the pancreas, the beta cells. And as those cells are slowly destroyed by the immune system, our blood sugar rises. So insulin is needed to take sugar from the blood, put it into the cells, into the body, where it can be used as fuel. So as that blood sugar rises, it reaches a critical point, at which point it starts to spill out in the pee, causing increased urination, which leads to increased thirst. And then the body is not getting any of those calories, any of those fuels. So we see weight loss, often with intense hunger. So we call that the classic triad: polyuria, polydipsia, polyphagia. If that process continues and the body can't get fuel from sugar, it needs to get fuel from somewhere else. So it starts to break down the muscle, the fat, and it makes these things called ketone bodies, which are really good fuel for the brain because the body will always prioritize the brain. But over time, if that continue, these ketone bodies are essentially acids. The acids build up in the blood and it can make someone very sick. That's something called diabetic ketoacidosis, or DKA, and it is a life-threatening complication of type 1, and about 1/3 patients present in DKA at time of diagnosis, and DKA is something that can happen once someone is diagnosed as well. A real quick note on the diagnosis of type 1 diabetes. The main thing we use is something called the hemoglobin A1C. It's a blood test that's basically a 3-month average of blood sugar. An A1C greater than 6.5% is considered diabetes. If you have that classic triad and symptoms and a random blood sugar over 200, that's diabetes. There's some other definitions, including oral glucose tolerance tests, but we don't really use those here, and these are certainly the main clinical parameters we use. Okay. So type 1 diabetes is on the rise, and thankfully, so are therapies and technologies. And there really has been an explosion of new therapies and technologies in the diabetes space. So I'll direct your attention to the top right of the slide. Those are what are called continuous glucose monitors, or CGMs. They are wearable devices that essentially monitor actually interstitial fluid sugar, but the algorithms and the technology has gotten so good where it's essentially equivalent to blood sugar, and we can make our treatment decisions based on that. But it gives us constant data and constant readings. If you don't have a CGM, or before the time of CGM, it was finger sticks, which I'm sure most of us are familiar with. You poke your finger, get a test strip, that will read the blood sugar, but it just gives you a static number. It gives you 112, not 112 with an arrow, and you have no idea which way that 112 is going. The bottom here, I have a few different examples of insulin pumps. So these are devices that are worn as well, and they deliver short-acting insulin subcutaneously and at a constant rate. Most of these pumps are changed about every 3 days, though there are some exceptions. But what has really propelled this field is the ability of the pumps and the CGMs to talk to each other. So we call that the hybrid closed loop system. And that's where, again, the pump will get that constant feedback from the CGM, and it can essentially increase, decrease, adjust the amount of insulin the patient is getting without any input. Now, while that is a great advancement, good care and control does take constant input from patients. We don't quite have that artificial pancreas yet. We need to enter when carbs are being eaten, constantly interacting with the technology, making sure it's calibrated, making sure it's working well. With all these forms of therapy, there are also newer forms of glucagon. That's our rescue medicine for severe hypoglycemia. It used to just be a vial and some powder that you'd have to mix together in the middle of an emergency, give with a big injection, really daunting. We now have intranasal versions, we have preloaded pens, and what's really exciting too is immune therapy. And in fact, the first immunologic therapy FDA approved to delay the onset of type 1 diabetes was recently approved a few years ago, and it's really the spark of hopefully a whole new generation of therapies. So a little bit of background on type 1. I hope you can appreciate that management is constant and complex. So having that constant blood sugar data is great, but it can be burdensome. These patients are making dozens, if not more, of daily decisions related to their type 1. We tell our patients there's no such thing as being overprepared. You need to anticipate low blood sugars, high blood sugars, anything in between. One of the frustrating things about type 1 is you can do the same thing on 2 different days and get a totally different result. There's so much that goes into someone's blood sugar, more than just what are we eating and what's our insulin dose. And as you can imagine, this can really impact everything, school, work, the family dynamics, and as we'll see, mental health. So again, more patients, more technology, more complexity. We need new and better systems and approaches to care if we're going to make a difference. So the spark, kind of where our quality journey all began, the Beatson study. So back in 2017, our division was awarded a grant from the Beatson Foundation. And, funny enough, our quality story actually begins with a research project. So this was awarded by the Thomas J. Beatson Foundation, which is a philanthropic organization based in Arizona. However, they contribute to programs all across the country. Thomas Beatson lived with type 1 diabetes for over 70 years. And it was his mission to not only fund research, but really improve the lives of people living with type 1. So we built this grant proposal on a study done about a year or two prior on 10 high-risk families, showing that we could reduce their hospitalizations if we increased support. And I'll talk about a little bit what that means in detail later on. So we wanted to get some of this grant funding to see if we could expand this model to a larger population. But also at the time, we knew we needed to change our division. We wanted more research presence, more quality presence. So a lot of this grant helped us develop the infrastructures that we can kind of do this work going forward. And I also have to mention that the grant provided and continues to provide medications and supplies to underserved patients. Okay, so the actual Beatson study. So this was, again, a research project to evaluate the feasibility, acceptability, and efficacy of more coordinated care. And what we initially focused on were patients with an A1C greater than 9.5%. The goal, A1C indicating good control for someone with type 1 diabetes, is less than 7.5% or even less than 7% if we can get there. So these were patients considered high risk. We were able to enroll 40 patients, up from 10, and they all had an initial assessment by our endocrine psychologist, Dr. Puffenberger, who's also still with us, because mental health plays such a role. And in addition to their 3 to 4 month standard of care visits with the diabetes providers, they received increased contact from certified diabetes education and care specialists, or CDEs. We sometimes just refer to them as educators. Now, a CDE, what is a CDE or a CDC? Yes, sorry. The old version is CDE, so I sometimes reflex to that. But they are a medical professional with additional training in diabetes care. They're basically our diabetes specialists. They come from multiple different clinical backgrounds, often start as nurses, dietitians, and they get this additional certification to be diabetes specialists. And as I'll show, they really make up the backbone of our clinic. They are the experts. So what we saw with the Beatson study is we were able to clinically and statistically improve A1C in these high-risk patients. Went from an average of 12% to 10.8% over 8 months. What may even be more important than those clinical outcomes was we showed through statistical and research methods that we were able to improve their quality of life. Both patients and parents got questionnaires, and we saw true improvement of quality of life there. That along came with decreased school days being missed due to diabetes and decreased hospitalizations. So we proved the acceptability and the efficacy with that study. So patients responded to our efforts, better A1C, outcomes improved with quality of life and missed visits. But how about the feasibility? Because for the Beatson project, we had staff members essentially review all our patients. It was one at a time, try to identify high-risk patients. How do we expand that principle and practice to our population of 1,800 patients with diabetes at that time? Okay, enter the diabetes dashboard. So Dr. Vaidya gave an excellent talk at Quality Day last year about the power of dashboards and basically the ubiquity of dashboards throughout our Phoenix Children's system. And this is our type 1 diabetes dashboard. This is actually an older view of it. But just to give a sense, a dashboard is essentially a living, kind of breathing representation of what our clinic looks like and what's happening in the moment. And they're linked to our electronic medical record system, and they can give us a wealth of data. This is just one tiny component of our diabetes dashboard, but it gives us a real snapshot of what our whole clinic looks like. So we can see patients who were recently in the ER, who are currently admitted. How are we doing with those patients following up in clinic? What's our A1C looking like? Education, again, you can see lots of components here. So dashboards made data actionable, and it helped our processes become more efficient. What I have here is a snapshot of, again, one of the subsets of our diabetes dashboard, but our location dashboard. So this helped us look at our different clinic locations throughout the valley, see what patients are being seen on what day, how is their A1C, where do we need to allocate our resources. So it basically allowed us to better pair our educators with our providers and ultimately also more easily identify those patients who were at high risk, not just one at a time. So with the dashboard, we essentially implemented a protocol that stratified patients by A1C, and that determined our level of intervention and effort. This process underwent a lot of different revisions over 3 years, and what I have here, this is clinic median A1C over time, starting in 2020 through early 2023. And what I really want to focus on is 2022, because that's when I think we really started to see true systematic change within our clinic. So, wouldn't be a quality talk if I didn't give a really good SMART aim, right? So this was our project back in 2022, and our aim was to increase the percent of patients seen by both an educator and provider at the same visit from a baseline of 38% to over 50% within 3 months. So I think I got all the components of the SMART aim there. Our interventions included developing an educator assignment grid so we could, again, match our educators with providers more closely. And essentially what this did was create teams of educators and providers. And then a big change were these daily e-huddles. The educators would email the providers in the morning. It would be a list of our upcoming patients. What data were we able to download ahead of time, meaning, their CGM data or their pump data, who might need more help. And it allowed us to start the day with real intent and purpose. We were able to be proactive versus being reactive. Now, we started at a baseline of 38%, which, sounds kind of low, but again, our culture and approach back then was that all patients should receive an educator visit at least once a year, because that's what's recommended by the ADA. So we would go in as the providers or take a look at the chart and did our patient see a provider within the last year? If so, okay, we're good. Don't need an educator. If not, let's peek our head in the educator office, see if someone could come in and help us. So again, a very reactive process. The huddle made this proactive. And in just over 3 months, we were able to increase that percent from 38% to 54%. And a bit of a spoiler alert, 4 years later, we are now at 90% and basically have been consistently above 75% for the past few years. So what we noticed as we continued to increase those touch points with educators, we continued to see improvement in A1C, and that was that chart I showed a few slides ago. So we initially focused on those higher risk patients that we were able to identify with the dashboard, but we know that educators and increased touch points helps all patients, including those who are well controlled. Not only did we do quality projects with the dashboard, we really applied QI principles to our dashboard development and evolution. So we had and continue to have monthly meetings with our IT department along with our quality team. We kind of look and see how are we doing with our data, what's working, what's not working, what can we change? And kind of asking ourselves, what else can we measure? Because if we can measure it, we can improve it. So that brings us to equity, access, and social determinants of health. So as we also increased our touch points, we noticed that there were significant disparities when it came to CGM use, continuous glucometer use. And what I have here is just one tiny snapshot of the data that a CGM can provide. We get this as the provider, and what this is actually showing is 2 weeks of time, basically every patient's blood sugar transposed onto a chart that lets us look at patterns and trends. We can see their time in range, their time low or high, their average blood sugar standard deviation, patterns of blood sugar throughout the day. Looking at this specific report, looks like maybe our patient's coming home from school having a snack. Are they not covering it super well there at 3 p.m.? Do they need a stronger carb ratio? We can look in and walk in with intention. So it's really invaluable data, not only for the patient, but for the provider. So we wanted to really understand our clinic's use of CGM data. So we went back to some kind of research methods, and we did a retrospective review of our clinic data. And what we found was that there was less CGM use and higher A1C in our Medicaid population. Now, insurance coverage should not have been the issue with regard to that because Medicaid covers CGMs for people who have type 1 diabetes. But, we figured that navigating that process could be because, we do know it was a little harder to get CGMs approved. We needed a little extra documentation, sometimes more prior authorization. So we felt that this was the opportunity for another quality improvement project. So what we set out to do was standardize the way we prescribe CGMs for newly diagnosed patients. When a patient was admitted to the hospital with diabetes, we started that prescription process right away, and we handled it more internally with our experts who knew the system back and forwards. And what we saw was that this resulted in actually significantly earlier CGM use. We increased from a baseline of 58% to 80% use by that first outpatient follow-up. So when patients are diagnosed after or discharged after a new diagnosis, they see us about a month later. So 80% of those patients had CGM data. So, not only was that invaluable for the patients because that first month is a time of incredible change and flux, but we as the providers can walk into that first visit and really have a good sense as to what's going on before we even start talking. We also wanted to look at percentage of that second follow-up, which is about 10 weeks after hospitalization. And we saw, significant and actually similar increase for both our private and Medicaid population. We increased from 84 to 94% for our private insurance group and 53 to 64% for our Medicaid group. But, as is very clear here, there is still a large gap despite standardizing this process. So this told us there's something more than just the process and more than just standardization that needs to be done. That's where social determinants of health come into play, or SDOH. So there are a few different definitions. This one here is the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a person's health and quality of life. So essentially what that's saying is, the factors outside of the doctor's office that affect someone's health care. You may have heard that, your zip code may be more important than your genetic code when it comes to health and life expectancy, because there are several studies linking things like your neighborhood, food access, education to life expectancy. So all things being equal, we might be able to tell you more about your health with your zip code more so than any other single piece of information. So Phoenix Children's has done a ton of great work within social determinants of health, especially over the last few years. And what I have up here, many of you may be familiar with, but this is the institution-wide social needs questionnaire. And what it is, it's sent to all of our outpatients to be filled out ahead of time before a visit. And it really addresses different factors of SDOH. And you can see a few of the questions here. The first one is about food insecurity. There are questions about transportation. Question 6 talks about, would you like resources for mental, emotional health counseling? So it's a way to capture those factors outside of the doctor's office when they come in to see us in the doctor's office. So since we had this tool, we were able to take a look at the questionnaire responses and then look at our CGM use and see if we could make some correlations. And what we found were that CGM non-users had substantially higher social needs burden. And what that chart is showing is the largest burdens there came down to mental and emotional support, as well as food insecurity. But you can see across basically the list of everything, our non-users were significantly higher than our CGM users. So I think that helped us kind of understand that CGM use was not just a patient preference issue. There was more going on. Families who were facing significant barriers were less likely to use CGMs and therefore benefit from the technology. So it changed the way we thought about adherence. If you are having issues with food insecurity, transportation, mental health, that CGM use is gonna fall lower on that list. So we wanted to try to redesign our systems to see if we could help with this. And what we did was we added a CGM section to our patient questionnaires that we send out to our outpatients and into our clinic notes. This is a snapshot of what that looks like within one of our clinic notes, but the patients, again, are sent a brief questionnaire that tries to capture what's going on. If we're not on a CGM, why? And that then, again, allows us to be proactive and try to address the issue as we're, walking in and seeing the patient. And, if we can import it into our clinic note like this, I think I saw Dr. Vinay back there. If it's in a clinic note, we can make it into a dashboard, right? So this is a snapshot of what our CGM dashboard looks like. So again, this is within our greater type 1 diabetes dashboard, but just gives us a wealth of information. The dashboards, they give us a 20,000 foot view, or they really let us look at everything, but then we can also hone into the individual patient. We're able to sort patients by insurance, by provider, by their last visit. And as we looked at these questionnaires, we tried to sort the reasons as to why we were not using a CGM and further address those issues. So again, it allowed us to proactively identify barriers. So if it was an insurance issue, if patients marked off it was insurance, well, we know insurance covers CGM. So how can we help you navigate that insurance system? Is it a technology issue? Do we need to update an app on the phone? Do we have the wrong transmitter? Do we need to get into your Bluetooth? Um, and of course, a large portion, as I showed, were psychology, mental health issues. And so how can we help get plugged into our endocrine psychologist, outpatient psychology support, and with some of those other barriers, further involve social work to help overcome. So what we saw after a few years of this intervention was a real significant increase in the use of CGMs in our Medicaid population. So that's what I have on this chart right here. And we wanted to really accurately measure CGM use when we thought about what's the definition of CGM use. We actually used whether or not our providers were entering a CGM code for CGM or a CPT code for CGM use, because that meant there was a certain amount of days of data that the provider was looking at that data and then actually using it to inform treatment decisions. So this is a pretty strict definition of CGM use. And despite such a strict definition, we were able to see real significant increase. Not only did we see an increase, we really saw a narrowing of the gap between our private insurance and our Medicaid users. At the beginning of this phase, CGM use was about 15% higher in the private insurance at baseline overall. And as of now, on the same graph, we're at 79%. So we've narrowed the gap, cut the gap almost in half. So I think that shows that, our interventions are helping outside of the doctor's office. So up until now, I've gone over a lot of what we're doing in the outpatient world. But of course, inpatient is important and has its own, while there are lots of similarities, it has its own set of unique challenges. So I want to talk a little bit more about what's going on the inpatient side. And we'll specifically talk about identifying and supporting our high-risk patients in the hospital. So again, I think we learned how important mental health and social determinants of health are when it comes to outpatient success. And there's no doubt that the same is true for our patients who are readmitted to the hospital. So we built another dashboard, of course. And what we did was we looked at patients who already had a diagnosis of type 1, but they came in for a readmission. And we wanted to really understand what were factors underlying these admissions. Could they be prevented? And how can we help patients to further prevent those? So another tab of our dashboard, really looking at all the factors at play when a patient gets admitted. And in 2025, we reviewed every single readmission we had and categorized it based on, again, whether it was preventable or not, what factors were at play. And that helped us learn a lot about what was really driving these readmissions. We had a sense before, but until we had the actual data, we couldn't be sure. So similar theme to outpatient, what was the leading cause? Came down to mental health issues. We also found that there were education gaps with regard to what patients should be doing when they're sick or when adjusting therapies. Lack of supervision was one of the top reasons as well, along with illness, missed dose, and technology malfunction, though those were less common causes of readmission. So now that we had this data at hand, we were able to work more closely with psychology, social work, and case management to, again, more proactively address these things. What we came up with was really a suite of interventions for our inpatient readmissions. The first one, which I brought up here, if anyone's interested, is we developed a known patient folder that just has different resources, which I have a few of which listed on the right, handouts targeted at the problem. So we could really, again, target that conversation to the family, have the conversation inpatient, but give them a solid, tangible piece of info to help if the problem occurred again. So there were things like troubleshooting technology. The bottom one there is sharing responsibilities. What should we expect from an 8-year-old with type 1 versus a 15-year-old with type 1? I think we hear from parents, well, this is their issue. They need to learn how to deal with it. Well, when you get admitted a few times, we have to maybe start rethinking about, what's appropriate, what do we need to do? Along those lines, along with our inpatient psychology team, we developed this behavioral health toolkit, which really covers a range of issues related to mental health and really complements our known folder quite well. What I have here is the table of contents of that behavioral health toolkit, but you can see it has things like family support, type 1 in the community, distress and burnout, which is a huge factor, once patients have had diabetes for a few years, different strategies for therapy, and of course, at the end, what's really important is our mental health resources. So in addition to that, we're trying to involve educators more strongly on the inpatient side of things with sooner check-ins after discharge. So if you remember that first Beatson study, we showed increased check-ins resulted in better care. We are now applying that to our patients who are discharged after readmission and ultimately attempting to get sooner follow-up for those patients. And we have a whole dashboard that tracks our follow-up as well. We also tailored resources for patients who are in more complex social situations, specifically those who are in DCS custody or group homes. This represents a really high risk patient population for coming back into the hospital. If a patient changes caretaker or goes to a new group home, it's our responsibility to know that they can take care of diabetes well. And for some context, when someone is newly diagnosed with type 1, it takes about at least really 2 full days of education just to make sure that families and caregivers know what to do. So many times when these patients changed caretakers, they actually needed to come into the hospital for admission just so we can teach. And you can imagine that's really resource intensive, not only for us, but puts a lot of stress on the system. So we developed a medical care plan, kind of an overview of how do we take care of type 1 in a situation like this. We've also vetted video modules that we have the new caretakers go through. And again, we get our educators involved. We assign these patients an educator as a coach to really ensure that all of these things are happening so that someone is constantly available with questions, to answer questions, and then again, to get them in closely for follow-up. And since we've implemented this new process, we've really been able to cut down on those admissions just for, education. I got to give a plug to Jesse's project because this is the most recent phase, I would say, of our quality journey, looking at these readmissions, something he's really passionate about and has done a lot of the work identifying these readmissions. So, if you want to learn more, hear more, you got to go visit Jesse and take a look at this poster. And, I think as hopefully most of you are realizing, these themes interventions are not unique to type 1, right? They can be applied to any patient population, especially those with chronic diseases who, end up back in the hospital. All right, so we're getting close to the end. So I really want to hammer down on the lessons we learned across a decade of quality work. So first, research and QI can really complement each other. We often, I think, treat these as separate entities. They do have separate days. But maybe we need to combine them going forward. And now, according to the IRB, they are separate, and it's important to keep those separate, right? But they truly complement each other. And when we, again, changed our division's infrastructure 10 years ago, we made efforts to build more research infrastructure, more QI infrastructure. And as we saw with our Beatson project and our CGM data, the research helped us define problems, make statistical correlations, and then QI helped us with our efficiency, our measurement, and allowed us to implement those solutions to scale. You can't improve what you can't see. So again, these dashboards, they made data actionable. and improvement visible, which I think is really important for buy-in and really help justify that the work we are doing is making a difference. When it comes to those social determinants of health, equity work really is quality work. We found that while standardization reduces variation, and standardization is incredibly important, it really helps us measure the outcome of a process. And that's why, so many of our clinical guidelines that we use, it's all about standardization, because then we can see, what are we doing? What do we need to change? And while we see some improvement with standardization, addressing those additional disparities required more. And that more is that, QI and quality work in general is a team sport. We couldn't fix all these things just within our division. It took collaboration with social work, psychology, IT, our clinicians, educators, program managers, everyone needed to work together to really get to that next step and solve the problem at hand. And what I would argue is the most important lesson of all is that culture change creates sustainable improvement. So without sustainability, a project is really just a project. And I know at Quality Day for our abstracts, a really important component of all this is, well, what's your plan for sustainability? Does this just go away if you leave or, once we move on to the next cycle? As I mentioned before, measuring improvement, and we shared our data. We had monthly meetings with our entire staff where we would give updates and really show that, what we are doing is making a difference in helping for buy-in and ownership clinic-wide from top to bottom. So what started as interventions and process measures of a quality improvement project really evolved into routine clinical practice. And I think this slide helps show what sustainability truly looks like. So what we have here are two variables. Our clinic median A1C there in the red with on the right side being the A1C values, our annual diabetes education being there in the blue. And there's a very clear inverse correlation here, right? As we are able to increase education, increase touch points, better care for all of a patient's needs, we continue to see the A1C decrease. Now, there's certainly an argument to be made, the explosion of technology I talked about. We have better tools now that certainly improves care, but we can't, patients can't use these tools if they don't have our help and our support. And what I think is really impressive when I was looking back at our clinic demographics over the last 10 years, we've been able to show this improvement despite really rapid growth, not only of the patient population, but of our clinic. Rapid growth comes with a lot of growing pains and challenges. We went from 1,500 patients in 2017 to now over 2,500 unique patients with type 1 that we take care of within the Phoenix Children's System. Over those 10 years, we had 10 providers at the beginning of this. We now have over 24 since I lost count and are hiring new ones every day. We had 6 diabetes educators back in 2017. We now have 12 and we need to hire more. In fact, we have opening positions. So go find Leanne if you're interested in becoming a diabetes educator because we need the help. But it really comes down to this, right? Improving the health of a generation. So I was diagnosed with type 1 diabetes about 20 years ago, a little more than 20 years ago now, at the age of 16. So I have seen firsthand as both a patient and a provider, how the landscape of diabetes management has changed. This new generation of patients with type 1 diabetes have incredible tools at their disposal. But it's our job as a healthcare system to continuously review and improve upon our systems and processes so that all patients, regardless of background, socioeconomic status, can benefit the most from these therapies. And if we do that, we really do improve the health of a generation of patients with type 1 diabetes. And I hope I've shown that we've been able to do that over the past 10 years. So with that, I have too many people to thank. Of course, the quality department, Dr. Kelleher, Dr. Engel, our IT department, Dr. Vidia, our mental health and psychology teams, the Beatson Foundation. really the entire endocrine division, especially our division chief, Dr. Kapadia, he had that vision 10 years ago about structuring our clinic. And, without that structure and that support, none of this work is going to happen. Leanne, our clinic manager, Jesse doing a lot of work on the inpatient readmissions. Fran Hoekstra, she's one of our educators who was with this project from the very beginning and still sits in on all our meetings, and really the entire educator team and division. So with that, I'd be happy to answer any questions. Thank you. Yeah, hi, Vasu.
That was great. I think of the 10 years of Quality Day, I've viewed abstracts for a good chunk of those, and the endocrine studies usually do rise to the top as some of the most strongest and well put together. I think what's impressed me is a lot of longitudinal work, not just like a project. But how do you keep that momentum going when you're like, here's another dashboard, here's another pathway, here's another sign to stick up in your clinic, because there does seem to be some fatigue with like another intervention, especially as you're getting closer to the top. Now you're trying to move from 92% to 94%, right? Like,
right. Yeah.
Your scale of improvement is not as dramatic as some of the earlier ones you've shown. So how do you keep the momentum going?
Yeah, so thanks, Vasu. And I'm not sure if you heard that on Zoom, but the question was, how do we keep the momentum of improvement going over the span of 10 years? We have all these great tools, but how do we really use them most efficiently? And I think, again, it comes to the changing of the culture, which I know is maybe more of an abstract concept, but, with these dashboards and with our different processes, we kept our clinic staff, apprised of our successes, our data. And I think, even working in the clinic, it was palpable when a change was more than a process measure and a true like cultural and clinical shift. So when those process measures became true clinical measures, it allowed for sustained improvement. Now, QI is iterative cycles, right? So having those meetings in place where we see what's working, what's not working is essential. So as I said, about 10 years ago, we made strides to really implement an infrastructure for additional quality improvement, protected time, for research protected time. And it allows us to stay on top of our improvements, disseminate what's going on, and again, get that staff buy-in. And I think, if you'll talk to the educators, when I was going through this project and really thinking how our day-to-day changed, it was kind of crazy to me that we would like really just peek our heads into the educator office and say, hey, is anyone here to help with this patient? And now every morning we get this email with, here's our patient list, here's what we're going to do. And I don't think both the providers or the educators could imagine doing this in any way. So it's when, not just having the tools, but being able to implement them and taking ownership is what results in sustainability.
Question
Dr.
from
Hartley. Yeah.
So you can repeat this since we don't have our overhead mics in there.
Okay.
Can you speak to the more recent addition of the role of pharmacists in the co-management agreement and next steps of improvement?
Yeah, I can speak to it a little bit. So the question is speaking to the role of pharmacists with regard to quality improvement. And probably within our clinic, where we've had the most pharmacy support is actually on our type 2 diabetes end of things. As you all may be familiar, there's been also a boom of medications and technology in type 2 diabetes, with even larger barriers when it comes to getting things approved and navigating the system. And we have a pharmacist who actually comes in, works with us, and helps us with that process. So, I did highlight a lot of different divisions here. And with these newer therapies, newer forms, these new barriers, pharmacy help is essential. And this question is making me think that that's probably somewhere where we can do a better job and maybe explore, at least on the type 1 phase. So thank you for the question. Dr. Engel, yeah.
Thank you for a great presentation and all the work that you guys have done for the last decade on this. I'm really struck by this theme of having a culture and developing this quality culture. Something that really speaks to me too. You talked about it in terms of processes becoming second nature, but how have you seen it affect how people view their role and quality as part of their role? And how do you see us doing better with that as an overall institution?
Yeah. So Dr. Engel asking about how quality affects culture and how can we see staff and kind of everyone taking a part of that. I'll say, I know Dr. Kelleher mentioned this early. I know, Rick, you've been involved since the beginning. I feel like, our culture here at Phoenix Children's regarding quality has changed immensely since the first few quality days. So it is changing. And I think it's events like this, again, it's check-ins, and it comes down to this buy-in. And I have to keep going back to the educators because they have been such a central role to our efforts, but also to our patient care. We talked with them, we met with them, we went over our process measures. And, this really was a greatest hits, if you will, of our quality work. There were interventions and things that didn't work or that were too bulky. But when we kind of clued into something that was working and that we could show was working based on data, it really resulted in that buy-in. And yeah, as I mentioned before, quality needs to be top to bottom, right? You need buy-in from the top for support, but you need the people on the ground and front facing to the patients to take advantage of this. So we really uh, foster a strong sense of quality within the division as a whole. We have whole sections of our meetings to quality. So it's become part of our division's identity. So I think when you make it part of the identity with all staff, that's where you see in that improvement and that ownership. Vinay. Yes, please.
The reason for me to come up here is not just for Zoom, but I'm sure Rob will not repeat what I'm going to say on Zoom. So I have to be data and dashboards by themselves do not result in what you saw over here. What Rob left out from the key lessons is the nitty-gritty. And where is Dr. Kapadia here, or he's probably remote? But Rob and Dr. Kapadia, their participation every month, they come with the agenda. They come with the 6 or 7 endocrine diseases. They have a continuity from last month to this month. And they are the ones who are the flagships of how data and dashboards need to be used and are used. And this is not just, like you said, a flash in the pan. They have been doing that for the last 2, 3, and 4 years. And this is a flagship example of how it should be reproduced across divisions: intense participation, sustained efforts, and looking at data and taking action and making the needle move. So kudos to this division. And if anybody wants to learn from them, I think if there is something I would improve over here, is to bring additional division members who want to learn this. So have that rotating things with different division members, but amazing sustained work. And kudos to you, Dr. Kapadia, and the rest of your division, because they are all looking at. So this is not just dashboards, and I wanted to emphasize that. Thank you, Vinay.
Can we just take one more moment to congratulate and recognize you and your entire team and how you guys have improved the health of a generation? Rob mentioned culture change. I do think Quality Day has played a huge part in some of the sustainability and how we've improved as a health system over time. Our quality improvement leaders are here today. It's no coincidence that they're front and center. I just want to take a moment to recognize you guys as part of our Quality Day committee. It's truly making a difference for our patients and our staff here at Phoenix Children's. So today is a celebration. We invite you to join us throughout the day today. At 9:30, we are changing this room into a TV studio where our Shark Tank will be presented. And we would love to have a studio audience. This is where people who have great ideas that need a little bit of additional support will come in and make their pitch. So please join us. It's our inaugural event led by Dr. Babaraju and Dr. Shane. And I promise you it is not going to disappoint. So please come and help support that. We have our poster walk rounds out in the atrium at 10:30, and our executive leadership team will be present to participate in that. And then we're awarding 10 projects this year to help celebrate 10 years of Quality Day during our award ceremony. So thank you to each of you for showing up this morning and supporting us. And please continue to support your teams as we make our way through the day.
You did a great job. Here after you. Leading the way. Yeah, social is great, like all of our safety, so yeah. Yeah, you should work from other.
Hi. Yeah, it's honestly the name of the IT team. And that's the hard thing, right? But I'm sure they're talking about the keys, your specific processing and the dashboard. I think somebody mentioned, right? All this. Yeah. Leadership management process. I contacted us 4 or 5 years ago. And met this quality management. If you actually, it's one of the first pages of the quality has more information on it. It actually shows this. One people involved and it's available that the provider and it's